All right, well, let's go ahead and get started. I want to thank everybody on the call for spending part of your Friday with us. It's been too long since we've all been in person. I know that most of you were able to go in September, but I feel like I missed out somehow due to effects of the pandemic, et cetera. So I want to welcome you all to the winter meeting here today. And we're going to be talking about advocacy today, and we're going to get a couple of perspectives. Joseph Cantrell from the ACR, who heads up the state affairs division. So he's all aware of legislation that has passed and is in the process of being passed across the country. He helps coordinate the ACR's support of these measures. And so he'll give you his point of view and give us some perspective on some of the laws and bills that have been passed in other states and how that has affected the practice of rheumatology. And after that, and Dexter Schott from the NMA will be coming. He's the lobbyist from the NMA and helps out with and manages everything advocacy and regulation related to this. And so he will be giving us a fine points detail of what's happening in our unicameral this year. And before we get started, though, I want to give a little time to Janssen. We want to thank Janssen and UCB for their sponsorship of today's meeting. And so I will turn it over to Dave, who's going to give us a few moments here.
Hi, good morning. Hi, everybody. Thanks for having me this morning. And it's interesting, what I do goes right in line with what you guys are talking about this morning. So I'm the Healthcare Policy and Advocacy Director for Johnson & Johnson. I cover Colorado and Nebraska for state level issues on policy. And it's our goal to preserve your relationship with your patients, so you're the one making the decisions, and to remove any barriers to access to care. So I'm non-commercial. I don't sell anything that J&J makes. So Carmen and I did try to coordinate a little bit so I don't overlap with Dexter and Joseph on any policy issues. So Carmen, seriously, please just interrupt if you know that, look, we're going to be talking about this. But the first thing I did want to let you guys know about is in Nebraska, the step therapy bill that did pass last year that your society did endorse and sign on to. So that went into effect January 1st, and it gives you and your patients a lot of rights with the insurance carriers to navigate the step therapy process. It does not prohibit step therapy. It just makes it a more clear process. It puts guardrails around it. It requires the insurers to respond to you in a timely fashion. And if they don't, then your exception requests are automatically granted. And it also gives you the ability to override step therapy under certain conditions, like if you think a medication that they're requiring you to use first would cause an adverse reaction, decreased functionality, cause mental or physical harm, or the patient is currently receiving a positive therapeutic outcome on a prescription drug on their previous health plan or current health plan. So it's a little bit of a non-medical switching language built in there. We're at the point where this just went into effect, and so it needs to be pressure tested. So, make sure that you and your staff know about this law that is now effective, that you test it with carriers, and if they're non-compliant, that you report that. I'd love to hear feedback on that too, if there's anything I can do to help. So that's the phase we're in, is really just make everyone aware, try it out, make sure it's working. If it's not, report it to the Department of Insurance. The second thing I wanted to let you know about is a bill that is coming up. I'm honestly not sure if it's going to get any traction or not, but it was just introduced last week, and it's LB 718, and it's on accumulators. So accumulators are programs that insurance companies, PBMs, put into place where the cost sharing that a manufacturer may pay for a patient, so a copay card, you have other assistance programs that may pay for part of a drug. Those typically in the past have counted towards the patient's out-of-pocket deductible and their out-of-pocket maximum. But the PBMs have found a way to capture that money and not count it towards the patient's out-of-pocket costs. And so what'll happen sometimes is if the patient's on a very expensive medication, those support programs do have caps. So sometimes in the middle of the year, the program itself gets capped out. Then the patient goes to the pharmacy to fill a prescription, and they have not paid their deductible yet in the eyes of the insurance companies. They're starting from zero. Now they have to pay their deductible, and they're not in a position to do that a lot of times, and they abandon therapy and get poor outcomes. So many states have enacted accumulator bans, and that's what this LB 718 pretty much does is it just says you have to accept payment from any source to count towards the patient's out-of-pocket deductible or maximum, and it shouldn't really matter where that money is coming from because the insurance company shouldn't get paid twice. Most of these bills do end up having provisions in them that say you can't steer a patient away from a generic to a brand. That doesn't make any sense at all. But if there's really no other alternative, then cost sharing should be incorporated and included in that patient's out-of-pocket. So those are the two big ones in Nebraska. And then from a federal level, I'm assuming Joseph's going to touch on this, but the public health emergency was just extended. It's extended in 90-day intervals. So it's going to go through mid-April with all the provisions around that being extended. The biggest one being telehealth, but last year Nebraska did pass a telehealth bill. And so the telehealth provisions of the public health emergency will not expire in Nebraska when the public health emergency expires. So that's a good thing for you, your patients, and your practices. So I think that was all I wanted to really touch on and leave a minute if there's anything I missed. I know I only had 5 minutes and wanted to be respectful of that, but those are the big ones that you'd want to be aware of.
Dave, question, Rick Chatwell here. Where do we actually get the step therapy rules? Where are they?
They haven't been posted as far as I know yet, but it's going to be regulated by the Division of Insurance. The easiest thing to do, I think, is just look up the bill. It's LB 337 from last year. It's only 3 pages, and it's pretty much written in bullet point where you can see what do I need to tell the insurance company to exempt this step therapy. Great question.
I appreciate it. Thank you.
You bet.
I just want to add that I did touch base with Brian Henderson too at the CSRO, and they have created a form that you guys can use to kind of help circumvent the step therapy process. So I can share that as well.
That would be great, Carmen. Thank you.
Yeah, Carmen, afterwards, if you can just circle back an email with some things from the meeting, that would be awesome. Thank you. Well, thank you, Dave, and thank you for your support of the meeting. We appreciate all your input previously and currently. So thank you very much. Okay, we have Joseph Cantrell up. And so Joseph works with the ACR and works with the states as an ACR liaison, if you will, helping states pass legislation, and he has seen the benefits of legislations like we have upcoming here. So he's going to give us a little bit, a big overview of what he sees as the biggest upcoming trends and what he sees as some things we can do on our level or here at the state level to help out with the care of our patients. So I will turn it over to Joseph.
Thanks, Marcus. And I've pre-recorded my presentation, so I'm going to share my screen, and hopefully this goes off without a hitch. Never know though. So good morning, everybody. I appreciate the opportunity to be here. My name is Joseph Cantrell. I'm Senior Manager of State Affairs for the ACR, and appreciate the opportunity today to talk to you about what we're doing in the advocacy space at the federal and state levels. Appreciate Marcus and Carmen for inviting me. I've had the pleasure of working with Marcus on several issues over the past several years. His time as court chair, so really appreciate being here with you today. So here you see our top policy priorities for 2021. We are obviously not in 2021 anymore, in 2022, but a lot of these priorities stay the same. We are still working heavily on the Medicare cut issue. We're heavily engaged in a lot of coalition activity around this, and there's still a lot of discussions going on. So we're really hard at work on that. Prior authorization and step therapy continue to be priorities for us at both the state and federal level. And kudos to Nebraska for joining the Step Therapy Club and passing step therapy legislation last session. Really happy to see that. and excited to see that continue to roll out across the states and hopefully be successful in Congress with the future passing, hopefully, of the Safe Step Act. We're still heavily engaged in research funding, particularly with the Department of Defense and expanding arthritis research funds that are available through the department. It's something we've been really engaged on for the past few years now, and will continue to be heavily engaged on. Really, is just to be perfectly honest, it's probably not going to happen this year, but we are hopeful that we're laying the groundwork for getting that funding in the next year. So we are playing a little bit of a long game there, but we're still working on that issue. Workforce, we are still working on increased funding slots, loan repayment programs, both at the federal and state level. The visa issue continues to be occasionally pop up and be a source of discussion. I really haven't heard it much lately, but it is one we continue to monitor. Drug costs and PBM reform continue to be issues, particularly at the state level. We continue to see a lot of legislation pop up, and we're really active on that issue through the Alliance for Transparent and Affordable Prescriptions, ATAP. We do a lot of advocacy work, and recently expanded into judicial advocacy, which is new for us. So we filed amicus briefs in Rutledge versus PCMA in the Supreme Court of the United States and in the Eighth Circuit in Wave versus PCMA. And happy to say that we came out on the winning end in both of those cases. So it's a new, exciting area of advocacy that we're really making a big impact in. And I'm excited to see how we continue to build that out in the future. But having a legal background, it really is exciting to see us looking at how we can advance rheumatology practice through the court system, because it is a area that we've probably underutilized in the past. So now we'll turn to the federal portion of the update. I can't get really in the details here because this is slightly out of my specific area of work, but I can give a general overview of what's going on, or as is the case most of the time these days, what's not going on. Gridlock seems to be the name of the game for the foreseeable future, just because of the dynamics we see and the split between Republicans and Democrats in both houses. It's really difficult for legislation to move, and neither party really seems to be that interested in working with the other, and I really don't see that changing anytime soon before the election. In spite of the gridlock, we do have a lot of bills in Congress that we've been working to support and move. Workforce bills, drug pricing bills, Safe Step Act in both the House and the Senate, prior authorization in both the House and the Senate, the DEXA reimbursement bill in the House, 2 different telehealth bills that we've been really supporting out of many that have been proposed, the pediatric subspecialty loan repayment program that, I'm going to knock on wood, hopefully actually gets funded in the coming budget. Things look more promising there than maybe they ever have, because we actually have a line item now. Before, we had authorization for the program for years, and it was never funded, but it looks like we actually have a line item now. So that is really, really a positive development that we're excited about. So another key component of our federal advocacy is our advocacy with federal agencies, particularly CMS. And one of the big things CMS does every year that everyone pays attention to is the fee schedule. And I'm happy to report, and you probably are already aware, there's no changes to last year's revalued E&M codes. It's a really positive development for rheumatology. So we're happy about that. Additionally, the telehealth flexibilities that we've enjoyed through the pandemic are going to be extended through 2023. It's likely going to continue as long as we're in a public health emergency. Who knows how long that is? Hopefully that's not too much longer. I think we're all ready for this to be over with, but it's just the world we're in right now. We are looking, though, at how we can permanently extend those flexibilities in a way that's healthy for the practice of rheumatology and helpful for patients and physicians and other providers. Because the flexibilities that we've all sort of were forced to adapt to in the pandemic world, there are benefits to it, and we just have to make sure that it's done smartly and not in a way that threatens the physician-patient relationship, the provider-patient relationship, and not in a way that views telehealth as a substitute for in-person um, appointments and consultations. So we've got to watch those developments through the regulatory process and the legislative process, but we have the team to do it, and we're staying on top of it. I think as good as anyone in the business can right now. Also, another development is the rheumatology MIPS value pathway will be included in the first set of value pathways for implementation in 2023. Another important note is this conversion factor, which you see down here at the bottom bullet point. This is actually incorrect and needs to be updated. The actual conversion factor that CMS settled on was $34.60. So that's a little bit of improvement in the final rule that came down. So I'm happy to report it's not quite as low as this number, the 33.58, but it's still a cut, just not as deep as we feared it could be. So now we'll move on to the state portion of the update, which this is my area of work, so this is something I'm very familiar with. We'll sort of start things off by looking at where things stand at the state level, give you kind of a lay of the land nationally, which states have passed things like step therapy, prior authorization, the issues that are really high on our priority list. So we'll kind of go through that and let you see where you stack up against some of your neighbors and states across the entire country. So we'll start here with looking at step therapy reform, and congratulations Nebraska on getting it done last year. It's a really big accomplishment, and just want to give really a word of praise to the medical society and the folks that helped lead that effort there. I can tell you from firsthand experience, these are usually multi-year efforts, and sometimes 4, 5, 6-year efforts. In the case of 2 other states highlighted on this map, I was really personally glad to see Oregon and California finally get it done. Those states, year after year, propose step therapy reform, and it would fall short. We see the same thing happen in Massachusetts, Pennsylvania, Florida. Every year we get these bills, they move, we get promises, it's going to happen, it's going to happen, it's going to happen, and all of a sudden it doesn't, for whatever reason, whether it's pulled out of a larger bill as a compromise, or a speaker doesn't like the bill. It's frustrating. So congratulations, Nebraska, for getting that done. It's a really big accomplishment. Be proud of yourselves. And hopefully we can keep adding some states to the list this year, even though I don't think step therapy is going to be quite the mover it's been in the past. Really, the next big thing we need to tackle there is the federal Safe Step Act, and really bring in some of those ERISA plans and things that the state step therapy bills don't touch. So it really, I think this issue, maybe more than any, illustrates the need of the dual track with the federal and state approach, just by the nature of the way insurance is regulated. I'm sure most of you know ERISA plans, Medicare, all is regulated by the federal government. And then you have state-based plans that are regulated by the states. And it really, to protect every patient in a state, you've got to have a state and federal bill. So the dual track process is really necessary in insurance and healthcare. It's frustrating because a lot of times you get these bills passed, especially step therapy, and we hear from our members and providers in states that have passed it that, hey, it's not made a difference. This hasn't done anything. And the reason it hasn't done anything is because we haven't got that federal piece of legislation yet as a companion. So passing the Safe Step Act is really going to make things better, I hope, from a step therapy perspective. And hopefully we get that done in the next few years. It'll be exciting. But we'll just see how things develop in DC. And now move on to prior authorization reform. And we had 3 wins this year. And I really want to spend a minute on Texas because it's a little unusual and an anomaly on this map. And that's because they passed something called a prior authorization gold card. Now, what this does essentially is if you have a 90% or greater approval rate on your prior authorization requests, you get a gold card. You don't have to go through prior authorization approval anymore. That's a really big win. It's really unusual to get something like that in a state the size of Texas, sort of as a first win. There were some unusual forces at work that made it possible, but it's also created a lot of buzz around this issue. And we know there's going to be, we've already seen a couple bills and we've been working on some ourselves with state medical societies. There's more coming this year. So this is a innovative concept. It's a unique concept. It was first proposed by the AMA, but it's got people excited, and I think physicians in particular are excited about this and the idea of getting a gold card. I think the one thing we have to watch out for in Texas is anytime you set a mark like 90%, I think it's reasonable to expect payers to try to keep providers just below that 90% threshold. So we're going to have to watch out for that in the implementation. I think over the next year or two, we'll probably have some anecdotal stories from Texas to know whether or not that's actually occurring. But I wouldn't be surprised. Payers are looking for any advantage they have, and I fully expect them to try to do something there just to keep providers from getting that gold card. But again, really, really innovative piece of legislation. Just wanted to highlight that for you, and hopefully one day we can roll something similar out to Nebraska. I'd be glad to help with something like that there. And another big issue last year was copay accumulator policies. And we saw 7 states pass accumulator policy bans. You can see there were a number of other states that actually had active legislation. We do expect most of these to see active legislation again, except for Texas because they're only in session every other year. So this will be another really active issue in 2022. It's also an issue that's prime for action in an election year. It gives legislators a way to go back to their constituents and really demonstrate how they've made a difference in the bottom line of their constituents. This is a pocketbook issue for a lot of folks. So I do think by the time the state legislative sessions start to wrap, we're going to see a lot of these states start filling in with copay accumulator legislation. So the last map we'll take a look at before we move on is non-medical switching. You can see New York passed the non-medical switching bill this year, the only state to do so. Governor Hochul signed it on December 23rd. Really pleased about that because Governor Cuomo had previously vetoed it, and we really didn't know where she landed on the issue. Fortunately, she came out on the right side and really, took a giant leap forward for New York patients to protect them against mid-year formulary changes. And we really hope to see this start spreading out more than what it has to some other states. It's really an issue that impacts a lot of patients. It's really important to rheumatology patients because whether we're talking about mid-year formulary changes or switching as stable patients, this is something that is really impactful for the patients that you treat. And it's just an issue that's hard to get traction on. Part of it is there's so many other issues around healthcare. I think non-medical switching just kind of naturally takes a back seat. And you'll notice some of the states where it's colored in, it's states that have kind of gone through. They've passed step therapy, they've passed prior auth, not Florida, but they've passed these other bills and they kind of work their way down the list. So I think non-medical switching maybe just goes down their list of priorities. But for rheumatology patients and for us, non-medical switching really is a high priority. And the last thing I'll talk about just before we move into the final few slides is Y bagging. Now, I don't have a map slide because if I did, it would just be a picture of Louisiana because Louisiana is the only state that's passed a Y bagging bill so far. Now, that's hopefully going to change this year because there are more than 15 states that are going to be considering this legislation, including Nebraska. And we're excited about that. And for those of you who aren't familiar with Y bagging, it is when a physician provider is required to acquire physician administered drugs through a designated preferred specialty pharmacy, usually owned by the PBM or the plan or the conglomerate that owns the plan and the PBM and everyone else in between. So it really is a threat to the buy and bill system and a threat to a lot of independent small practices out there. I've noticed in the conversations we've had that folks who practice in an institution maybe are a little more insulated from this issue. But it's really the small and independent practice that gets hit. And one of the big things that I've heard is the potential for increased waste that physicians are no longer able to bill for. So it also creates this access issue down the pipeline because if you can't buy and bill, if you can't get reimbursed at adequate levels to cover your acquisition costs, then eventually you're going to stop doing it. And then you have rheumatology patients that can't go back to the rheumatologist to get physician administered drug. And, now we have an access issue. So it's really about maintaining that provider patient relationship and giving the physicians the tools they need to give the patients the drugs they need when they need it in the amounts they need it, not dictated by a plan or a PBM or any other entity that doesn't have a medical degree. So that's the goal. And we're excited about the progress we're hopefully going to see on this issue in the coming year. Like I said, we've been engaged in many, many states on this so far, and we're just in January. So hopefully when I come back next year or someone else from ACR comes back, they'll show you a map of states that have passed Y bagging restrictions, and this will all be colored in a good bit. So hopefully this is going to be a big year for Y bagging. So before we wrap up, I just want to touch on a couple Nebraska specific priorities that we have. I think no surprise here, 1A and 1B, Y bagging restrictions and accumulator ban. Those are just going to be such salient issues this year. And I think a lot of times you have to strike while the iron's hot and really go with the issue that has the most momentum. And I think we're really going to see these two issues emerge as the two where we see the most wins in the states this year. We are going to see PBM wins. There are a couple of PBM bills we're watching in Nebraska. I didn't list them because we don't know which one's more likely to move at this point. And there's just always new PBM legislation coming. They're everyone's favorite punching bag right now, and we're happy for that. But we will be engaged in the PBM legislation moving forward, and excited to see what Nebraska comes up with there this year. Hopefully something gets done. I would urge you, while we're on this slide, when and if you see an action alert coming on any of these issues, to fill it out. it really is helpful for legislators to hear from their constituents, particularly constituents who are educated on an issue. In a time when everyone thinks they're a doctor, it's great for them to hear from the folks who actually are. So it's really important, I think, now more than ever for you to be engaged. So if we do an action alert through our Legislative Action Center on wide bagging, accumulators, PBMs, what have you, just take a minute and fill it out. It really does more good than you could possibly imagine. And a lot of times, what moves the needle isn't necessarily a relationship or a conversation, it's the volume of input that they're getting from constituents. So when you contribute to that volume, you're really helping to move the needle more than you know. On a final note, I want to thank our Nebraska Room Pack donors. These really are advocacy all-stars. We really appreciate the folks who step up and make Room Pack donations throughout the year. And just wanted to give those folks a shout out here and say thank you and encourage you, if you haven't made a donation, to do it. The pack really is important and one of the most powerful tools we have to help leverage our voice in Congress. I hate to say that money creates relationships, because it's not supposed to. That's not how it's supposed to work, but it's just the nature of the business. Most of these folks are in constant campaign cycles, so Room Pack really is a great tool to open the door to create some relationships that we wouldn't have otherwise. So I really encourage you all to take a minute and make a donation today or soon if you haven't. So to wrap up, I just want to thank you all again for inviting me here today. I hope this has been a useful, informational, 20 something minutes of your time. And I'd be happy to take any questions you might have, and hopefully I'll get invited back at some point and we can do this in person instead of online. I think we're all getting tired of video screens.
Hi, this is Rick Chatwell here. Question about speaking to legislatures, especially with these three particular priorities, the white bagging, accumulator, and PBM legislation. Does the ACR have any particular talking points that we can share with? I mean, I'm not sure what language the legislators need or want to hear that is going to steer them one way or the other.
Right. And I appreciate the question. On some issues, we do have talking points. Sometimes we have one-pagers, particularly on issues like step therapy, where we've been engaged for several years. With white bagging and accumulators, I don't think we have those, but we can definitely come up with those. And the talking points would be in the action alerts anyway that we send out. So if you're looking for talking points, that's a good place to look for it. We usually have them highlighted or bulleted in those alerts somehow. So that's a good place to look. But if you're wanting to engage with a legislator and you're not sure about that, you can always reach out to us and we can provide you talking points, even if we don't have them already written out in a form that you can just access. So if it's something you're willing to engage on, if it's these issues or anything else that you're confronting in your practice, we can definitely work with you on talking points and messaging around those issues.
Do we just contact your office? Is that what we do?
Yeah, and actually Carmen and Marcus both have my email, so they can provide you all with my email address, so you can just reach out to me directly.
Good, great, thank you.
Yep.
Any other questions we have out there? So the one that I had that I thought popped up, so the step therapy bill, I think you mentioned this and you touched on this, but I just wanted to make sure that everyone on the call understands the limitations of the bill that we passed in Nebraska last year. It only applies to, and Dexter, Joseph, jump in if I'm wrong here. It only applies to plans that are managed by the state. And so ERISA plans, or plans which are from your employers, are not covered by our state step therapy law. And so that's why he touched on the need to have federal legislation and state legislation so that the federal legislation would cover employee and government issued plans. And so that's why the ACR, even though we may have wins in Nebraska for step therapy, that would only apply to state administered plans.
Yeah, and I would just echo that. And something I mentioned too in the presentation is don't feel frustrated if you're not seeing a difference in your day-to-day practice after that bill is passed, because I would venture to guess that most of your patients are either Medicare or ERISA patients anyway. So that's going to be the bulk of your practice. So you may not see a big impact after the Nebraska legislation, but it's an essential component. And all the wins we've had on step therapy at the state level has moved the needle at the national level. I don't think we would have had that federal bill without all the gains in the state. It got people's attention. So it really is a necessary part of the process.
Great. We will move on. Thank you, Joseph, for your time. And hopefully, for those of you who weren't on the beginning of the call, he's been dealing with a sick toddler. And so that's why he had a recorded session during his time here. So we appreciate his time. His email is listed here. Feel free to contact him. All the folks at the ACR are very responsive. And if you have any questions, email him or email us and we can get you in touch. All right. We will move on to Dexter.
All right, good morning, everybody. Happy Friday. I don't have slides for you. Bill introduction just finished yesterday in the Nebraska legislature. So I just finished reading bills yesterday, so I haven't had a chance to prepare any slides, but I have my handy dandy bill chart in front of me to go through things. And I apologize for the lighting. My window's right here. So normally I have sunlight right here, but at this hour, no sunlight in the winter anyway. So the Nebraska legislature began its second session of the 107th legislature on January 5th. This is the carryover session. Last session was 90 days long. This session will be 60 days long. Bills from last year do get to carry over to this year. And as I mentioned, there was bill introduction still for this session, the first 10 days. We saw a large amount of bills. Typically in this shorter session, there's only about 400 that get introduced. We saw almost 600 this go around. And to put that in perspective, on my chart, I'm tracking almost 70 bills. Last year, we only tracked just under 60. So a little strange to be tracking more in the shorter session. And the main reason for that is the ARPA funds pouring into the state from the American Rescue Plan Act that Congress passed. The state of Nebraska is poised to get $1.04 billion in ARPA funds. So most of the bills we've seen are appropriation requests for those funds. There is a lot on healthcare and primarily a focus on behavioral health. Behavioral health, rightfully so, has been front and center. And I would look, in the coming year and next year, you're going to see a massive expansion of behavioral health services across the state in partnership with UNMC and Children's Hospital. But there's requests for all sorts of things. But fortunately, we're glad to see healthcare get several of those requests. Real quick, I'll touch on the legislation the NMA is working on this year that we introduced. One is an ARPA request. It's to send $10 million to the Rural Health Student Loan Repayment Program for physicians, among others, working in a practice area that's deemed a rural shortage area out in the rural parts of the state. The practice requirements are a 3-year requirement. And if a physician goes out there and completes that, they do get student loan repayment. That program has had a wait list the last several years, so the demand is there. Hence our ARPA request to send funds over there. The governor in his budget did increase the appropriation this year, so we were glad to see that. But with so much money on the table, we're only asking for not even 1% of the total ARPA funds coming in to go to that program. So we feel pretty good about that one. There's two bills that are linked to that. So if you're taking notes, it's 1007 and 1269. Both were introduced by Senator Dave Merman, who is a rural senator. And then the NMA also helped introduce LB 739, which was introduced by Senator Bostar. This reduces the age insurers must cover colorectal cancer screenings from 50 to 45. That matches a recent recommendation change by the USPTF, and I always get that acronym wrong, so forgive me. Unfortunately, that piece was in our law. Normally, we wouldn't like to see things like that in our law, so that recommendations could just automatically apply. But since it previously was in our law, we have to go in and change that age from 50 to 45 to match that. Luckily, we do have the health insurers on board, so that one should pass no problem. I'll go into the three that you've kind of already heard about that really pertain to you guys. And that's legislation surrounding PBMs and the work of PBMs and what they do. Joseph, if you're still on, the one to note down for PBM regulation that is the one to watch and will likely pass is LB 767. This was reintroduced this year. It's almost the same as the one that was introduced last year. As you heard, we did pass step therapy last year, which was a huge win. We did it in 1 year. And I think that really speaks to Nebraska's uniqueness. Every legislative bill receives a public hearing in Nebraska. So every bill has a chance to get heard. That is much different than a lot of the other states. And Joseph will tell you where the parties control what bills get hearings. So that's why you hear that some bills take 5, 6, 7 years to do work. We were able to do it 1 year because we had a chance to get in front of legislators, get physicians, get patients in telling those stories on step therapy. And the same happened with PBMs as well. That hearing was quite extraordinary. I think the insurance committee was kind of floored at the stories they heard. And that's why pharmaceutical, pharmacies, insurers, and then providers then worked during the interim this summer to come up with an agreeable plan that everybody could get on board with. And that result is LB 767. So that's the one that I would, if I was a betting man, I would bet my house that that will pass this year. Well, maybe not my house, maybe my car. I need my house. And then as you heard, 718 is the accumulators and cost sharing provisions introduced by Senator Moorfeld. That was the piece that was taken out of last year's PBM bill. So they split it. That was the piece that all the parties agreed could be taken out this year and worked on separately. So that's why you see that bill on that specific topic. And then the white bagging bill is LB 943. The NMA is working on that one with the Hospital Association. They were the ones who introduced that legislation. And I do know if that doesn't pass this year, both them and us are fully prepared to go at it again next year. So there's where those lie right now. Real quick, I'll touch on scope of, and I do want to mention the hearing for 767, which is the PBM bill. I'm glad I didn't forget this. That hearing is actually Monday. So if you would like to tune in, all the hearings stream on nebraskapublicmedia.org. It is in the Banking, Commerce, and Insurance Committee, and Dr. Caitlin Britton, as I understand, will hopefully be there to testify both for the Rheumatology Society and the NMA at that hearing. Like I said, this bill has kind of been worked on throughout the year, so I don't think the need is quite there anymore for the patient stories and that type of thing that we saw last year, which is fortunate. Sometimes we see this where bills were worked on, everybody's in agreement, so we really can save everybody's time at the hearing. So we're looking forward to that one and looking forward to seeing Dr. Britton hopefully on Monday on that one. I just want to mention scope of practice quick. I know that generally doesn't impact rheumatologists too much, but as physicians, I do hope you do watch scope creep from other providers. We did not see any scope of practice bills this year from the psychologists who have been trying to get authority to prescribe psychotropic medications. nor did we see a bill from the optometrists this year who have been trying to do certain eye procedures and injections. Those were two that we've seen the last several years. We were glad to not see them this year. That means the only scope bills left are ones that the NMA actually worked on with the applicants, and we are in support of. The first is LB 752. That is for respiratory therapists. This one is kind of an unfortunate story. DHHS last year gave an opinion to Children's Hospital that respiratory therapists technically were not supposed to be operating the ECMO machine, which is a very vital tool, especially during COVID. So this one was put together quickly because obviously we cannot have those providers technically operating outside the scope of what the regulator views they are able to do, even if they have been doing it for the last 20 years, as I understand it, in Nebraska. So we did support that one, and that one is moving and was approved in the 407 process. And then the other one is 1249. That one was also approved in the 407 scope expansion process, and now we see a legislative bill reflecting that. That one deals with medical nutrition therapists. They are basically splitting into two. So we had physicians review to make sure there wasn't any expansion of scope there, and there's not. So we are on board with that one as well. And physician consultation remains a piece of the Medical Nutrition Therapists Practice Act. So we were glad to see that. So those are the two scope bills. So no real big scope of practice arguments this year. And then I will just highlight some bills of interest that you might want to be aware of. The first is LB 753, introduced by Senator Arch of Papillion. This one requires, and I'm not sure how much you guys dabble in this space, but this one requires informed consent for stem cell based therapy treatments that are not FDA approved or have approval for investigational drug use. Senator Arch is really trying to get at the couple clinics in Omaha. As I understand, there might be one run by nurse practitioners, another one run by chiropractors that are using stem cell based therapies that are not FDA approved. So hence, and I understand there are some lawsuits involved with the Attorney General. So that's where this bill stems from. It requires informed written consent for those procedures. But again, if it's FDA approved, it does not apply. So that may or may not apply a lot to you guys. We did see some bills, really, it's an election year. So we're seeing some hot topics, some social issues. There's bills prohibiting schools from teaching critical race theory, of course, even though, just a little side note, as someone with a political science degree and a law degree, I never once encountered critical race theory. So I'm just going to throw that out there. So I doubt our kindergartners will as well. But bills are out there to prohibit the teaching of that in our public schools and to prohibit the teaching of sex ed, which is unfortunate in our public schools. There are several bills to ban abortion. There are several bills to expand abortion and contraceptive access. So, we see the give and take there in this election year. So a lot of the floor debate this year is unfortunately going to be some election year grandstanding on topics like that. I want to draw your attention to 862, and I point that one out because this one was actually a product of our Creighton medical students. They devised a resolution at the NMA annual meeting to have Medicaid cover emergency dialysis services for undocumented persons. And then they were able to get a senator to introduce the bill. So we love to see that. So we appreciate the work of the Creighton medical students on that one. And it just shows, anybody is able to, as I kind of said before, anybody's able to come and introduce a bill and get a hearing on the topic. So we will be talking about that in the Health and Human Services Committee, whereas in another state, that bill likely would have been buried and not seen the light of day. There is a bill 895 introduced by Senator Walz that will rein in prior authorization restrictions only for MCOs. We heard Joseph talk about prior auth legislation in general. I know the Hospital Association is interested in Illinois' approach. We are definitely interested in Texas's approach, and the AMA has really touted that one. I'd like to see some gold cards here in Nebraska, but this bill 895 only impacts Medicaid and Medicaid prior auths with our managed care organizations. It requires prior auths to be reviewed by somebody, any appeals to a prior auth to be reviewed by somebody in that specialty. So as a specialty, I'm sure you guys will appreciate that if you're dealing with Medicaid. And then it makes certain requirements on the issuance of payment for clean claims and things like that. And caps authorization, it has to be taken care of within 48 hours. We saw a couple COVID related bills. There is a bill 859 that would seek to remove Lincoln Lancaster County's exemption. That's able to issue DHMs on their own. We're seeing that fight play out in Omaha because the argument is that Omaha does not have that authority. So there's a bill that would remove Lincoln's authority so that everybody fell under the state, which we find unfortunate. We would like to see local control there. LB 906 would require the Department of Health and Human Services to create an exemption form for vaccine requirements. And then if an employee hands that form to an employer, the employer has to accept that form as an exemption for vaccine with no medical basis or anything. That the employee just has to sign it, and the employer would be required to accept it.
And Dexter, that's all vaccines, right? Not just COVID.
Yeah, all vaccines. Thanks, Carmen. So we will be watching that one and likely be opposing that one. One definitely for your attention is LB 963. This was introduced by Senator Merman. I had a question. Bill number for Medicaid prior auth 895. Dave. 963 is the Adopt the Medical Ethics and Diversity Act. Some of you may remember this one if you've been a longstanding NMA member. This topic came up about 10 years ago, but this bill would allow healthcare professionals, institutions, facilities, and payers to reserve the right to not pay for or participate in any medical service that they deem objectionable to their conscience. So it's one of those types of bills. It then goes further than the one 10 years ago. If a practitioner or an institution, facility, or a payer is religious based, this bill then would authorize them to use the religious beliefs in making business decisions. So things such as employment or contracting or even privilege admitting decisions. They could use religion to base that in. So this one is going to be an interesting discussion of our members at our legislative meeting next week. I'll plug that if you're an NMA member. Next Wednesday at 5:30 is our legislative meeting where we will be discussing these bills and determining the NMA's position on them. Couple more real quick just to point out. 1133 introduced by Senator Moorfeld. We were glad to see this one. This one would allow, or this one would put healthcare professionals into the workers' comp statute that allows for workers' comp to be received for any mental anguish. So that was great to see after the last few COVID years. It would qualify healthcare professionals to receive workers' comp if they did have any lasting, side effects, mental side effects, PTSD from COVID work. 1168 is interesting, introduced by Senator Linehan, who is the chair of the Revenue Committee, so the committee that sets tax policy. This would allow for an income tax deduction of out-of-pocket medical costs. I suspect the fiscal note on this one will be rather large. Previously, the NMA actually last year had a resolution exploring this, and I ran the numbers, and it was a lot of money that the state would lose out on. So I'm interested to see where that goes and what that fiscal note looks like. 1175 is interesting. This one was just introduced the other day by Senator Justin Wayne of Omaha. It would prohibit insurers from removing providers from their network for solely financial reasons. we did like to see this. We would like it to be a little more specific, but especially with the No Surprise Act coming up, we've already seen in other states physicians being dropped from the networks because they do not agree to come down to the lowest average repayment that the insurer offers. So I would hope that this would cover them, because that would be a financial reason to drop from the network. So we're going to work with Senator Wayne to kind of see how we can get this kind of dialed in. The language is really broad. It's a paragraph, so it would definitely need some work, but it's a great idea. And then finally, yesterday, the very last bill introduced, we did see another medical marijuana legislation. We were not expecting another one this year because Senator Wishart of Lincoln, who normally brings this bill, is again working for the ballot, towards the ballot in 2022, just like they did in 2020. So she had no interest in reviving her medical marijuana bill from last year. So the one that was introduced was actually from Senator Mike Groney, one of the most conservative senators in the legislature from North Platte. It is definitely scaled back from the other ones we've seen, certainly from what Senator Wishart's proposals were. It would only cover 4 conditions: stage 4 cancer, uncontrolled seizures, muscle spasms caused by multiple sclerosis or muscular dystrophy, or terminal illness with a life expectancy of under 1 year. So it's a lot more narrow. I believe Senator Wishart's bill had about 15 conditions compared to 4. And there's some other differences under Senator Groney's program. The state patrol would essentially run it, which I don't know that that's the best policy decision to make, but that's why they hash it out in committee and on floor debate. I know I ran through a lot there, so I'll stop and open to any questions on anything regarding our legislature. But again, bill introduction is over, so we will not see any more bills. Hearings started last week, and the NMA has been active in hearings this week in the HHS committee on a variety of topics. So we are in full swing of things.
We're running a little short on time, but I will have folks can email you, Dexter, with any questions or things that pop up.
Yeah, of course.
I know you're very busy right now, but I would just direct emails there. I'm gonna also, thank you for all your work and all your help on this. And I would also just ask that that if you need anything of us, just make sure you communicate through Carmen and communicate to us, and we're more than happy to help.
Certainly. Thank you.
Thank you very much. All right. So before we sign off here, Lene is going to talk here from UCB, and we appreciate UCB's support of today's meeting, and I will turn it over to UCB. So I'll let everybody get back to their Friday. I want to thank you all. We'll have a meeting information coming up in the near future for the summer. We have a fall meeting planned, and it's going to be in Omaha in September, and we'll be giving them more information as we move forward on that.
Have a great cold weekend.
Have a great one. Thanks.
Thanks,
Yeah,
everyone.
bye-bye.
Thank you, everyone.